Hi, my name is Dr. Michael Schiff. I'm at the University of Colorado School of Medicine in Denver, Colorado. I'm a clinical professor. Today, I would like to present the highlights of an oral presentation from EULAR 2013, and that is the head-to-head comparison of subcutaneous Abatacept to Adalimumab on background Methotrexate in rheumatoid arthritis. 2-year results from the AMPLE study will be presented today. This presentation actually made the major podium because it is very, very important. It's very important both from a scientific but as well as from a clinical standpoint. We as clinicians, when we see patients, we really want to know what's the best thing we can do for our patient. We know that the randomized controlled trials that are done are usually done against placebo, and again, almost always done against placebo, and that is to obtain a regulatory, that is an FDA or an EMA approval. But when a patient comes to see us, we really aren't going to choose placebo for that patient. We really are going to choose an active therapy for their rheumatoid arthritis. And what we really want to know is the comparative effectiveness of the therapies that we have available. And the good news is that we now have many therapies that are available for our patients with rheumatoid arthritis that are obviously effective and effective more than placebo. But this comparative effectiveness has become quite important. Many people are looking into this, but there's very few head-to-head trials, especially this one, which is the first and only head-to-head trial on the standard of care, that is Methotrexate in rheumatoid arthritis. Prior to this trial, we would use things such as randomized controlled trials, but again, those would only have comparators, but would not be powered, as this trial was powered for efficacy to compare two active agents. We used indirect treatment comparisons, such as the Cochrane report, but again, that compared one trial to another and really didn't have this kind of head-to-head comparison. Databases have been used, and EULAR has also shown us that databases have some bias, and therefore that's why head-to-head comparisons are so important. So let's move on and take a look at this trial. So again, this trial was patients with active rheumatoid arthritis. These patients had disease by protocol of less than 5 years, but it turned out they had less than 2 years of disease. They were treated with the standard of care, and that is a non-biologic DMARD, and all of these patients were then on methotrexate and had an incomplete response to methotrexate as monotherapy. Then what happened is the patients were given either one of two very well-known active compounds, either Abatacept in the subcutaneous form now, or Adalimumab. And we know both of those agents are very effective in rheumatoid arthritis. This trial was done for 2 years. It was blinded for 2 years. This is the only trial that's ever been blinded for 2 years, which gives us significant power in our data analysis. The 1-year data was presented at EULAR 2012 and then published in Arthritis and Rheumatism just recently. And again, this data showed that subcutaneous Abatacept was equivalent to Adalimumab on standard of care or background methotrexate. Here, and at EULAR 2013, I presented data to show us that the blinded 2-year data shows that both of these compounds are efficacious, and the 2-year data gives us some insight into safety because our patients need information about safety, and we as clinicians need to inform our patients about long-term safety. Again, what do these patients look like? They look like the standard population that we would see in the office. Again, most of them were Caucasian women, which is what we see in all rheumatoid arthritis studies. They had, again, as I mentioned, disease duration of less than 2 years, which is pretty standard. Patients were treated with non-biologic DMARDS and then methotrexate. And then if they had an incomplete response, this biologic agent, either subcu Abatacept or Adalimumab, was added. These patients had very active disease. They had very high DAS scores, They had high tender and swollen joint counts, and you can see this on the data from the slides. These patients, despite having only 1.7 to 1.9 years of disease duration, these patients actually had sharp scores or erosive scores of about 24. So these patients had very active disease and had a lot of erosive disease and were very significantly affected by their rheumatoid arthritis. So moving on in the data analysis, what we saw in year 1 and presented and published showed us that both subcutaneous Abatacept and Adalimumab, for the onset of action or the kinetics of response, the depth of response for ACR 20, 50, 70, or a DAS score, or any way you measured it, were equal over the 1-year period of time. What's new at EULAR is the 2-year data. So from 1 year to 2 years, we have shown that subcutaneous Abatacept and Adalimumab on background Methotrexate, which is the best way to give these biologic agents, really tracked exactly the same, whether it be for ACR 20, 50, or 70. We also showed that the depth of response was very good, and these people had very high ACR 20, 50, and 70 scores of approximately 60, 40, 30. We also looked at remission scores, and we were able to show that 20% of these patients actually had the new, very difficult to attain Boolean remission score in both arms of this study. When we looked at it with the DAS score, the same was shown. The DAS score tracks exactly the same as the ACR scores, with significant improvement, both as the onset of action and the continued improvement, not only over 1 year, but now over 2 years. So again, to be a disease-modifying drug, you have to not only improve signs and symptoms, but you have to slow radiologic progression. So again, we looked at x-rays. And again, I want to remind the audience that this was blinded for 2 years. So the principal investigator, who was single-blinded, the principal investigator did not know that the patient was either on Adalimumab or subcutaneous Abatacept, in addition to their standard of care Methotrexate. There was no changes made in any of their therapies over the 2-year period of time. And what we were able to show, again, going back and rereading these x-rays at 2 years, was that the x-ray inhibition tracked exactly the same. 85% in both groups had no progression over 2 years of their x-ray damage, and only 15% had some damage, and this was only limited to a few patients. So again, signs and symptoms were improved equally. Radiologic inhibition was slowed or inhibited equally for both of these agents. And again, the next step was, now that we see that there was equality or comparability of these two agents on standard of care Methotrexate, to give the clinician a choice of either subcutaneous Abatacept or Adalimumab for their patients, was to look at the long-term safety. And long-term safety is very important. So why is long-term safety important? We really need a number of patients, and this is a large number of patients, over 600 patients, with a retention rate of between 75 and 80% of all patients being retained in this study out to 2 years. We were able to look at a large set of patients over a long period of time for adverse events. And that's really what's most important when we look at safety data. Again, we were not powered to really look at differences, but this was looked at by qualitative means. So again, there was one death in both groups. In the first year, a patient in the Abatacept plus Methotrexate group died. She was a 66-year-old woman. She had hypertension. She was on 4 antihypertensive medications and was found dead at home. No autopsy was done, and she was felt to have a cardiovascular death and was not felt to be related. In the second year, there was one death in the Adalimumab group plus Methotrexate. This was a 75-year-old patient who was also hypertensive on antihypertensive medications. He developed acute chest pain, was taken to the emergency room, had very high CPKs. MI was diagnosed, but did not survive. Again, not felt to be related to therapy. When we look at serious adverse events, all adverse events, again, the numbers were pretty much equal between these two groups. We looked at malignancies, the numbers were equal between these two groups. There were more autoimmune events in the Abatacept group versus the Adalimumab group. But when we drill down into what these were, this is something called the MEDRA tick box when we do clinical research forms for research. So there were 3 cases of psoriasis in the patients on Abatacept. One patient actually already had psoriasis going into the trial, but had classic rheumatoid arthritis. And we do know that psoriasis can develop on biologic agents, whether it be TNF agents or whether it be on a T-cell modulator like Abatacept. The other thing was there was 1 case of psoriasis in the Adalimumab group. Very importantly, there were 2 cases of dry eyes or Sika syndrome, again, tick boxed as autoimmune diseases. But at the end of the day, when we looked, only 1 patient in each group really dropped out because of what was called autoimmune diseases. The patient in the Adalimumab group was because of a laboratory test that's a positive ANA or double-stranded DNA, and the patient in the group of Abatacept dropped out, but did not appear to be a serious adverse event. So again, a difference between the two. Injection site reactions were followed in this protocol. It was done as what's called a hierarchical primary endpoint or secondary endpoint, and that meant that you had to meet your primary endpoint first, which was that these 2 agents were not different, which I think I've shared with you. And if you met that endpoint, which was a non-inferiority endpoint, which was met at the 1-year time point and again presented and published, then you could go back, and we did go back and look at injection site reactions. Again, for us as clinicians and our patients, what's most important is not if you have an injection site reaction, but if it's significant enough for the investigator and the patient to decide on stopping the medicine. So the good news, over 2 years, no patients who were given subcutaneous Abatacept plus Methotrexate had injection site reactions and had to drop out for this. But 3 patients with Adalimumab had injection site reactions that the patient and principal investigator elected, and they were blinded to what agent they were on, that withdrew these patients. So again, a difference, and again, no statistics are done on that. When we looked at serious infectious episodes, most of the serious infectious episodes that occurred were bacterial infections. The most common serious infection was pneumonia, but we already know that in rheumatoid arthritis patients, not even on biologic agents, rheumatoid arthritis patients, the most common serious infection is pneumonia. So that seemed to be the case here. Bacterial infections were the most common infection in the Abatacept plus Methotrexate group. Over the first year, there were not a lot of safety differences that could be elucidated. However, the second year of the trial, from year 1 to year 2, did show us that there were 3 cases that were of significance, primarily in the group that got Adalimumab plus Methotrexate. So there were 2 cases of tuberculosis, and we know anti-TNF agents are associated with tuberculosis. Both of these cases occurred actually in South America. Just to point out to the audience that this trial was done 75%, 3/4 of the patients came from North America, mostly the United States and some from Canada, and about 1/4 of the patients came from South America. And again, as we know, tuberculosis is more endemic in South America. And there was 1 case of disseminated histoplasmosis in the group who got Adalimumab plus Methotrexate. So again, a qualitative difference in the kinds of adverse events that we saw. So what does this tell us? What does this 2-year blinded head-to-head trial, the first head-to-head blinded trial that's been done over 2 years, looking at comparative effectiveness? Well, it tells us, I think, a lot. and it tells us a lot as a clinician. It tells us a lot to share with our patients, as well as obviously the science behind it. Again, when we sit in the office with a patient who takes methotrexate, and we know methotrexate is the cornerstone of therapy, and most patients with rheumatoid arthritis are given methotrexate first, and then if they don't respond, the biologic is added. This gives the clinician and the patient a choice that either they could add Abatacept or Adalimumab and feel that from the onset of action, the depth of response, and almost for the adverse event profile, that these patients could have equal benefit from either of these agents. And again, sharing that information with our patients is quite important. So I think that that's very, very important. Future studies need to be done with more agents, more comparative effectiveness studies, and more head-to-head trials. And again, these have been planned, and they've been planned worldwide, because this is not just a U.S. question, it's a question worldwide for patients with rheumatoid arthritis. Thank you very much for listening, and I'm going to move on now to some of the most frequently asked questions. So this presentation raised a lot of questions, and some of the questions we do have answers for, and some of the questions hopefully we will have answers for in the future as we do some more work. At the podium at EULAR, I was asked a very important question, and that is, well, if we have equivalent results from adding to the standard of care methotrexate, either subcutaneous Abatacept or Adalimumab, for efficacy and maybe some slight safety differences, how could we choose which patients in the office or clinic we would pick to give one of these agents to or another agent to? So we as clinical researchers and clinicians look at this in a number of ways. And the answer that I gave from the podium was essentially, we have already done a subset analysis to look at the patients to see if there was a difference with age, gender, disease duration, rheumatoid factor, or any clinical parameter that we could measure. If there was a difference, if we could pick out the patients who would be better responders to Abatacept plus methotrexate or Adalimumab plus methotrexate. And I'm sorry to say that we were not able to be able, from clinical parameters, to be able to tell that. We were also not able to tell which were the patients who are going to have more serious adverse events. We are currently, and as we speak right now, looking at what are called biomarkers. And biomarkers are very important. These are laboratory tests that we look at to see if, and there's a whole series of biomarkers that we're looking at to see if they would be predictive of the patient that we could choose as in the clinic or the office to give either one of these two agents. And that data hopefully will be done and available, and hopefully for EULAR 2014, and maybe you'll invite me back to give you that answer. The second most asked question is, given the fact that these two drugs look pretty equivalent, and they look equivalent for the onset of action, the depth of response, the radiologic inhibition, and maybe a little bit of difference in safety, can you really make a choice at this point in time? Well, when we as clinicians make the choice, we have the patient in front of us. And we have to remember the patients we see in the office and the clinic have comorbid diseases. They're not necessarily the patients in randomized controlled trials who have fewer comorbid diseases. So the choice of either an anti-TNF agent here, right, Adalimumab was chosen, or Abatacept, will have to be based on, obviously, the patient in front of us, their specific medical history, and obviously this data now adds a lot of information for the clinician to make that choice, and he has at least two equal choices. And then the last question that's been asked, because Adalimumab is given every other week and the subcutaneous Abatacept is given once a week, does that really make a difference for patients? And that really made no difference for patients. The injection site reactions actually were a little bit more of an issue. So again, I think this trial has given us a lot of insight and light into comparative effectiveness of biologic agents in rheumatoid arthritis.